It's going to be a lightning session. If you have questions, please post them on the code, on the questions for the panel. And without further ado, we're going to have Karen Gifford from WACS talk about her lightning presentation.
Been told by multiple people that I have to keep it to 5 minutes, so I've scripted this, which is a special kind of hell for me. So this is, I'm going to be speaking about the Stroke Tele Rehab Partnership, and Ruth Waugh is now the project manager of this project. It's a partnership between Osborne Park and Geraldton Hospital. So compared to their Metro Living counterparts, regional Australians have a higher prevalence of stroke, but poorer access to timely specialist stroke rehab, leading to poorer outcomes post-stroke. Stroke rehab provided in regional hospitals is often less adherent to national stroke rehab clinical performance indicators by generalist staff with variable confidence in providing stroke rehab. The Stroke Tele Rehab Partnership between Geraldton Hospital and Osborne Park Hospital's specialist stroke team aims to utilise telehealth to improve access to admitted specialist stroke rehab closer to home for country patients, reduce the frequency of transfer to metro hospitals, evaluate the cost benefit to the health service and Midwest patients in this type of stroke rehab, improve the rural stroke patient experience of rehab care, and improve rural allied health staff confidence in providing stroke rehab. So this project also serves as a proof of concept, demonstrating the need for the development of a funding model that supports the provision of metro-based specialist services to patients admitted at other sites, and in this instance at WACS sites. So this was achieved through Osborne Park Stroke Team using telehealth to join therapy sessions and the weekly rehab team meetings at Geraldton Hospital and provide clinical handover and stroke education, all via telehealth. So key changes to processes of care at Geraldton Hospital arising from this partnership include rehab consultant input into stroke rehab patient care at Geraldton Hospital, setting targeted length of stay and earlier discharge with TCP, and that also has ongoing Aussie Park specialist support. So I'm just going to focus on the first three of these results, but there's been increased regional self-sufficiency at Geraldton, decreased hospital length of stay, improved quality of care, improved or increased staff confidence, and high patient satisfaction. So self-sufficiency in admitted stroke rehab for Geraldton patients has increased from around 70% in the 3 years prior to the project commencing to 92% in the project timeframe. That is, almost all Midwest patients presenting to Geraldton Hospital who required stroke rehab have received their rehab within Geraldton Hospital, in most cases avoiding the need to transfer to metro hospitals. There are significant cost savings associated with avoided patient transfers to Perth of almost $5,000 to transfer a patient to Perth and approximately $1,500 to transfer a patient back to the region. The average length of stay for stroke patients at Geraldton Hospital has reduced by 39%, from 33 days prior to project commencement to around 20 days in the first 15 months of this project. So this can be attributed to a few things. Changes in practice at Geraldton Hospital for rehab patients under the guidance of Osborne Park Hospital Stroke Unit, and that includes introduction of the AROC length of stay calculator to better estimate patient length of stay, enabling early establishment of discharge date and likely functional improvement. And this results in earlier family meetings and home visits by therapy staff, discussion of length of stay in those initial goal-setting meetings that include the patient and the family, tailoring intervention to achieve required functional gains by the predicted discharge date, and discharging appropriate patients at a slightly lower functional level than previously, with support from the TCP, Transitional Care Program, with Aussie Park specialist support. The average length of stay for Geraldton stroke rehab patients in metro hospitals has reduced by 36%, from 22 to 14 days. This can be attributed to earlier discharge from Aussie Park Hospital and, in some cases, avoiding transfer from an acute metro hospital stroke unit to Osborne Park altogether due to the availability and promotion of rehab in Geraldton Hospital. And this is one of the key slides looking at data, so using stroke data to demonstrate practice improvement. Improved adherence to Australian Stroke Foundation clinical indicators of care have been recorded during the Stroke Tele Rehab project compared to the results Geraldton Hospital achieved in its last national audit prior to project commencement. The grey bars here indicate Geraldton's compliance with these prior to the project commencement, and the blue bars, the performance in as at June 30. So with all of them but 2 showing significant improvement. Some of these improvements can be attributed to explicit teaching and resource sharing by Osborne Park Hospital clinicians, facilitated by telehealth. Others are the result of quality improvement initiatives undertaken by Geraldton staff after opportunities for improvement were identified through Metro specialist input into processes for care through the weekly team meetings. And future directions are exploring outpatient in-home tele-rehab as well. Do we have time for questions, or shall we wrap it up there? Thanks very much.
Thanks very much.
So evidence-based practice tends to focus on the randomised controlled trial, or the RCT. RCTs are often not suited to... This is the wrong thing. RCTs are often not suited to rehabilitation environment because of the multidisciplinary nature. So there can be... change? Sorry. Sorry. So in rehabilitation, it is often not practical to use the RCT. The multidisciplinary nature of the rehabilitation environment presents challenges for standardisation. RCT selection criteria are often restrictive, raising questions about generalisability of results, and RCTs are expensive. Rehabilitation services can instead use observational data to generate practice-based evidence. This framework uses broad inclusion criteria and is suited to a multidisciplinary environment because patient differences can be controlled statistically. This proof of concept study shows that the Osborne Park Hospital Stroke Rehabilitation Database meets the framework for practice-based evidence and can provide data that will inform policy and practice. The database began in 1996 and right now contains multidisciplinary outcomes for almost 1,800 admissions. It presents opportunities to answer a variety of clinically meaningful questions, but has not yet been used in published research. Challenges in inconsistent measurement of outcomes, data entry errors, and clinician time for data entry are probably the reason the database had not been used to generate practice-based evidence before now. This year, we formalised the Data Custodian, Steering Committee, and Terms of Reference to ensure appropriate use of data and adherence to national and state data usage requirements. To ensure veracity of data, we use a data dictionary that is understood by relevant team members. Errors have been corrected retrospectively and missing data have been completed. An external audit to verify data accuracy is in process. The first research study using the database is underway. Lateral pulsion is a common impairment after stroke that is associated with slowed functional improvement and rehabilitation. It is not considered in the current ANSNAP funding model. The main aims are to determine the association of lateral pulsion after stroke with functional change, length of stay, and discharge destination after inpatient rehabilitation, and to determine how inpatient length of stay for patients with lateral pulsion compares with the average length of stay predicted in the ANSNAP funding model. This is a retrospective database analysis that conforms to the Strobe Statement for observational studies. It will represent data for more than 450 patients with lateral pulsion, which is the largest cohort of patients with lateral pulsion to date. The study will outline for the first time how the ANSNAP funding model accounts for expected outcomes for patients with lateral pulsion and will provide data that will inform resource prioritization and allocation by healthcare providers. Results will have implications for service delivery that can contribute to reducing long-term burden on the health system, carers, and community. The database is up-to-date and accurate, with systems in place to ensure data security and veracity, and now has the potential to facilitate observational studies that can inform care provision. There is potential for pooling with other databases and co-design of studies with other services. And it fits alongside daily clinical practice in a busy rehab environment. I want to acknowledge the team, and I'm happy to share my references if anyone wants them.
So today I'm going to be presenting on how we use the behaviour change framework to implement modified CIMT within Metropolitan RIF. I'd like to acknowledge my OT counterparts, past and present, Joss and Robin. I've seen her around somewhere because it was a team effort. Cool. So just some background. So if you look through the stroke guidelines, and today we're all very aware of how important the stroke guidelines are, and you look under upper limb activity after stroke, there's only one intervention that has a strong recommendation, and that's modified constraint-induced movement therapy. Only problem is in RIF, no one was using it, or very few, so I don't want to disparage those who were. So we had a go at trying to implement it. So a couple of years ago, we did a QI project. There were 4 of us involved, so 2 physios, 2 OTs, and I was really It was amazing collaboration. I thought we worked really well together. And then we developed 2 training sessions. So one at Royal Perth RITH, one at Fremantle RITH. And we did one session on an overview of modified CIMT and one on the motor activity log. Had over 30 staff attend each session, each of the 2 sessions. And no one used it. Or very few. I don't want to disparage that as well. So what did we learn? So implementing modified CIMT wasn't as simple as just providing some training and hoping therapists will run it. It's complex. It's not an easy intervention to practice, and it requires therapists to change their behaviour. So we worked together in planning our intervention, but we didn't include the therapist viewpoints in trying to plan our QI project. So I'm not going to pretend I know as much as Tash Lennon about the TDF. So we did use the TDF, and you can see the green inner circle is the COM-B, so the sources of behaviour. And then this is the TDF. So that the first circle is the behaviour change wheel, second circle is the TDF, where you've got the domains in yellow attributed to the COM-B. And this is a very busy slide, so I don't expect you to be able to read it. And there's a little poster somewhere out there if you want to read it. But essentially, we administered an online survey to our staff, our physios, our OTs, and our therapy assistants across all of our sites. And we grouped the themes into what the barriers were. We then attributed the theoretical domains they operated in, and then you can see that we looked at the behaviour change techniques and what modes of delivery we would do to try to address those barriers. So most common one we've heard is staff want to use modified CIMT, but no one knows how to use it. We know it's in the guidelines. How the hell do you use it? So that was the biggest thing. Or people weren't confident with their neuro skills. So we looked at workshops, journal clubs, small group discussions. So it's all still going. The other thing was about paperwork, and our first instance, we didn't make it context specific. So we've completely changed our paperwork to fit what fits our service. We've also talked about how it will look in our environment. So not how it looks in the Torb clinic in Alabama, not how it looks in another service, how it would fit for us. And we're treating patients in the home so that they have other rehab needs. So safety, those sorts of things. But we also looked at the enablers. So staff were keen. They just wanted to learn. The biggest thing was management was super supportive. So they were happy for us to deliver this training to all our staff, happy for us to do all of that. And the availability of myself and our OTs to provide expert support for all of our patients. So then we developed our implementation program. So we did 4 workshops at each RITH base. So there's 7 RITH bases. And we broke down the components. They were 90 minutes and they were small groups, so staff could have a real practice. We developed all our own resources, and we used feedback from staff to change. So that was a working document for everything, from the behavioural contract to assessment forms to information sheets. We've suggested that all staff come out, have one of us go out and join with a session so that they can see how it works, so they can see efficiencies. And now we want to look at providing opportunities for social comparison. So the staff that have used it have been adopters, and they try and find any situation they can use it. We want site champions. How'd I go for time?
So today I'll give you a brief overview of a research project that I did as a postgrad master's. I'm going to start with giving the members of the audience that aren't occupational therapists a brief overview of the Perceive, Recall, Plan, Perform assessment system. So it's standardised criterion referenced ecological assessment, which we can use to apply to any task to evaluate task mastery and cognitive strategy application. I really like it because it's basically what OTs already do. It's formalising it and making the invisible of cognitive processing visible and measurable. It standardises the assessment of what we already do, and it's something that is actually not a great onus to add in. So I think that's an important thing to start with. The study aims were to describe the cognitive strategies that are used by a cognitive in this cohort, and determine the relationships with standard measures that we were already collecting, and also to examine how long it took us to implement PRPP assessment. The setting was an early supported discharge service, which most of you know receives referrals from the entire metro area. For this study, only one site was selected, as that was where the most PRPP trained OTs were based. So it was a really small study. We just had to get the numbers and get get it done in what I could do as a component of my Masters. So there was only 10 participants that they were consecutively recruited, aging from 44 to 78. That to be over 18, less than 6 months post-stroke, with a cognitive impairment already identified on any standardised screen, able to communicate in English and able to consent. So as I mentioned, it was just one site that was used. The OTs, the primary OT was usually the person that conducted the PRPP assessment, and we also captured data on the Lawtons and the FIM, which may have been collected by any member of the team, and the FIM was done by the treating OT. Data was analysed using Excel and SPSS. In order to capture the patterns and results rather than individual scores, sample averages were calculated. The average time to assess one task was 28 minutes and 19 minutes to score. That sounds like a lot, but when you look at the literature, it's actually similar to many standardised cognitive assessments that we already use, such as the CAM or the LOTCA. The use of PRPP assessment also allowed for goal-related cognitive performance and may have facilitated client-therapist partnerships. We found that the average FIM score was relatively high, which wasn't that surprising based on the cohort that we had, but the average Lawton score was comparably low. This might reflect the increased cognitive demands that occur in the home environment, particularly in that early phase post-discharge. On stage 1, we found that the areas of accuracy were most prevalent, and that makes sense when you're thinking about people are starting to learn new skills or starting to apply them in a different way. But overall, it indicated ineffective performance. Stage 2 results, and we've got a lot of data on this is just a sample, suggest that the PRPP assessment revealed difficulties in perceive and in plan within this sample, components of information processing that are essential to learning new skills. Sub-quadrant analysis also demonstrated lower scores with sensing, evaluating and mapping. So when we think about what we found, it seems that the stage 1 scores were lower than suggested by FIM or Lawton, so indicating that people actually weren't performing as well as what we would like them to be doing or what you'd expect people to do in their own environment, given that these people have just come home. The PRPP assessment was well managed by the staff and accepted by the patients, and the time requirements were in line with many other assessments. As I mentioned, it formalises the non-standardised performance-based cognitive assessments that OTs often complete and can be applied with any task within the patient's rehab and in their own context, and doesn't mean that you need to go and apply another assessment. The PRPP identified difficulties in performance accuracy, attending and all areas of plan. These aren't areas that are addressed by the FIM or Lawtons or many other areas of occupational performance. And they're areas that OTs are commonly involved in post-stroke. As Fiona mentioned this morning, executive skills are something that we are all involved in, and it's a really key area of practice after stroke, and it was interesting that Plan captured some of that data. The correlations with Plan and FIM and Plan and Lawtons may be attributed to the areas that Plan does encompass, such as doing the shopping and performing new tasks. So these are the more complex things that we need to be able to do, and they're not the things that we target in hospital. Oh.
Bang on. Well done. Next talk.
This one's not as exciting. This is more a project that we did. But it's going to be a little bit less formal because it's kind of lessons learnt along the way. An acknowledgement to RIS staff for being so supportive in the last few projects that we're trying to get up and running. So when I was writing this talk, we went through some of our data, and I was a bit surprised to find out that stroke survivors form about 10% of our RIF caseload, but they are the people that require a lot of service events. So they might only be 10% in terms of numbers, but in terms of frequency of service and intensity, they're a large group. A service gap was identified in the consistent use of outcome measures by OTs for this patient cohort. And when I mean a service gap, it was quite an extensive gap, and I think OTs universally probably feel like there's no one-size-fits-all measure, and so it's quite difficult to do. So we found a working party to form and identify areas of practice for evaluation. So we looked at levels of the ICF, we decided which areas that we might want to evaluate, and we decided in the end that upper limb was the best way of going because it's something that's objective, quick, applies to a lot of patients. A lot of cognitive assessments, as you know, we can't remeasure. So then that discussion then became about whether we do it with the motor activity log or the motor assessment scale, and there was lots of meetings about that. And then we looked at the evidence, and then we had a bit of a discussion again, and we tried things. So now we've come up to the mass. So why did we go with that? One of the main things we needed was something that was quick, reliable and light. And I know light sounds silly, but if you're carrying like the ARAT, which is a pretty big wooden kit, across the hospital and then into someone's house and then someone's got it in the other car, like that doesn't work. We needed something that's actually kept in a Coles like reusable bag in the cars. And it's not, it's not expensive, so that's not a problem either if it's something got stolen or lost or left at someone's house or the dog ate it. It was quick to administer, so you can do the maths in 5 to 15 minutes. It's appropriate for a range of stroke survivors, and there's 3 subscales that we looked at. So we use the upper arm function, subscale 6, 7, which is hand movements, and 8, advanced hand activities. So we've looked at the evidence on different ways of doing the maths, and at the moment we're going with the 6 is hierarchical, 7 and 8 do all of them. So when I looked at the data, that was kind of a moment of truth where I realised that we haven't actually captured our data very well. And I think that the talks we've had this morning probably highlight some other lessons and some more robust ways of going forward. So from 2017 and 2018, we had 8.5 months of data from when this project started from 4 RIF sites, which is approximately 290 patients, but we only had 90 patients in our mass database. 2018 and 19 was 12 months of data from 5 sites, which is approximately 430 odd stroke patients, when we hadn't captured 88. Of those patients that were in our mass database, we found that there was an average change of 3 points for both financial years, which was interesting, so that seems to be kind of consistent. And upper limb, there was no clinically important difference known for the mass. However, research suggests that in upper limb measures that it would be sort of around 3 to 5.5 would be acceptable. So we went 3, that's okay. The other advantage of it is it allows for us to broadly classify impairment severity and also look at change. So in conclusion, we found that it's been successfully implemented in a time-limited service. We don't keep people forever, so we needed something you could remeasure in a short time frame. New staff receive upper limb mass training, and we've got, and that's something that we're just trying to keep rolling out. But as I said, I need to look further with our team about strategies for data collection and management, and how we're going to do that going forward, and also acknowledging that it's not perfect and there may be other tools out there that we want to use in the future. Thank you.
So today I will talk to you about predicting motor outcomes after stroke. So more than 475,000 people are living at the moment with the consequence of stroke in... Better? Okay, good. In Australia, I've never used this before. This is expected to raise to 1 million in 2050. Motor impairment after stroke is a prevalent issue, and 30 to 6% of all stroke survivors don't regain functional use of the upper limb. So how good are we at predicting the motor outcome upper limb function at the moment? So experienced clinicians find it very difficult to predict functional outcomes for individual patients. So when you only look at clinical scores, for example, some people with recovery potential can go unnoticed, and other people of which you expect that they will recover quite well, they might not recover as much as you expect. So this uncertainty complicates decisions around choice of treatment, therapy dose, allocation of the resources, and also what we found in talking to the patients and the family is really what the patients and the family could expect, because most of them don't know what to expect, which makes it very hard. So luckily we can go to biomarkers as well to help us to predict how well somebody will recover after stroke. So a biomarker is an indicator of a disease state that can be used clinically to reflect underlying processes that might be difficult to measure directly in humans. So I would now focus on 3 key areas in our study, which we think we can improve outcome prediction. So the first one is the input variables. So in our study, we're going to collect different biomarkers. So the first one is we're going to collect TMS, transcranial magnetic stimulation, to check the corticospinal tract integrity. So we stimulate the brain with the TMS. We record the muscle response in the hand to check if the corticospinal tract is intact. We will do also an assessment of the afferent pathways with somatosensory potentials. We assess voluntary motor function and sensory function. And also we look at general function, so non-physical outcome measures, including quality of life measures. Then we look at the data analysis approach. So we're going to take a machine learning approach. And the way you analyze data, also with machine learning, can make a huge difference. So this is some data of predicting how well people will respond to robotic therapy in chronic stroke, where you can see that depending on the machine learning algorithm that you use, you can significantly reduce the uncertainty in your predicted outcome. Last thing that I'm going to focus on is the sample size. So for this kind of analysis, we need lots and lots of patients. So therefore, we will set up an international study to get the number of subjects required. So these are the people involved. So the first site to go online is St. John of God in Midland. Then we're also going to analyze the data in respect to the health economics. So an existing algorithm, the PrEP2 algorithm from Katie Stenier, has shown that you can reduce, by implementing this kind of algorithms, you can reduce hospital stay with 1 week without negatively influencing motor function. Possibly through more individualized upper limb treatment. So also in our study, health economics will be involved to do some calculations to see if we can save healthcare costs. Secondary implementation of this type of algorithm would be in research, potential saving money because we can stratify patients, so we can reduce variance and increase power in your studies. And it also might give us prior knowledge of therapy effectiveness, allowing for patient stratification to appropriate therapies. So we aim to improve outcome predictions by using additional input measures, using advanced machine learning methods. And our approach will likely result in more reliable outcome predictions, potentially improving healthcare of patient outcomes and potentially saving healthcare costs. These are my references. Thank you.
So before beginning, I'd like to acknowledge the traditional owners of the land that we're on today. So Tooley's project was aiming to identify and compare patients' physical activity, location and social interaction on 2 different rehab wards at Fremantle Hospital. This was achieved through the use of behavioural mapping. Through utilising the protocol for behavioural mapping from the Blennerhaus study conducted at a Melbourne hospital, the project was also designed to evaluate how well patient activity level within our hospital compared to that of Melbourne Hospital. Finally, the data obtained allowed for an establishment of a baseline to allow for evaluation of the effectiveness of future CQI projects that were to be taken out on the wards. So participants, all patients were screened for participation in the study and selected through convenience sampling. To be eligible, they needed to be receiving rehab with exclusion criteria including anyone that was admitted on the day of observation, those that were planned for discharge on the day of observation, those that were unable to participate in rehab secondary to medical reasons, and those that were awaiting discharge to supported destinations. On V5, participants were also randomly selected to include varied mobility levels. So the project was conducted across 2 publicly funded rehab wards at Fremantle Hospital. So B7 South being a general geriatric rehabilitation ward that included a separate therapy area 50 metres off the ward, and V5, which is a predominant neurological rehabilitation ward that had 2 different therapy areas located on the ward and multiple joint areas or community areas for patients. During the observation period, patients and staff performed their usual activities, The protocol from the Blennerhaus study was followed, however, a change of observation was made with data being collected every 20 minutes instead of 10 minutes, as it was limited to one person being able to collect the data. 9 patients participated from the general rehab ward with 216 points of observation, with 1 patient being excluded secondary to an unexpected discharge, and 10 patients from the stroke rehab ward were observed, leading to 240 observation points. Patients were observed for a total of 1 minute at 20-minute intervals between the hours of 8 a.m. and 4:30 p.m, with a 30-minute break allowing for an observer's lunch. Each patient received 24 observation points throughout the day, with patient behaviour recorded at each observation. Patient behaviour included the patient's physical activity, social interaction and location. The study focused on the on-ward environment, and so patients' behaviour was only observed whilst they were on the ward. All observations were made by the same observer, who was independent of the participants' rehabilitation program and did not interact with the participants during the study. In relation to mapping physical activity, there were 17 defined items that were then characterised utilising a 5-point scale rating, from 0 being no activity and 4 being high activity. The highest level of physical activity performed in the 1 minute that the patients were observed was what was then recorded. The locations of the patients were defined as is above on the slides. If the patient was off the ward, it was recorded as being not observed, but their whereabouts was then clarified with nursing staff. In terms of mapping social interaction, the presence and role of other people with the participant was recorded at each observation point, including both verbal and physical interaction. When people were within the same room as the patient but not interacting with the patient, the participant was marked as being alone. So the amount of daily therapy varied depending on the patient's need and day of the week. Patients on the V5 ward followed an individualised timetable placed on their wall that was reviewed on a weekly basis, whereas the patients on the general geriatric ward, therapists assessed their need and scheduled their treatment daily accordingly. On V5, patients also engaged in a fortnightly enrichment program that was designed to promote cognitive, social and possibly physical activity. And there was also additional options for practice provided in the way of group sessions that included disciplines of speech, occupational therapy and physiotherapy. Whereas on 7 South, there was reduced time spent in groups. So there's 5 times a week combined exercise group with another rehab ward and 3 times a week breakfast group. The data that was received from the study indicated that on the general rehab ward, patients were in their bedrooms 85% of the time in the 216 observations that were made. 55% of the time they were on their own, and 5% of the time they were spent with allied health. On the stroke rehab ward, 43% of the time patients were in their bedrooms, 42% of the time they were on their own. I think I'm going to get nudged off.
Thank you. So I'll be presenting today on the results of a clinical audit that was undertaken as part of a bigger multidisciplinary quality improvement or research with a little project that was undertaken at the acute stroke unit, looking at the assessment for rehabilitation and also with the aim of trying to streamline, improve communication between team members and then also trying to standardise the assessment. So just a bit of a background information. So stroke unit trialists in 2013, they found that there was no firm grounds for restricting access to rehabilitation post-stroke, and when they conducted an Australian-wide audit, they found that 59% of people assessed were only assessed for rehabilitation post-stroke as the Stroke Foundation guidelines. And then the National Stroke Foundation guidelines in 2017 recommend that every stroke patient should be assessed for rehabilitation within 24 to 48 hours of admission to an acute stroke unit, and they recommend that that should be done on a standardised assessment form or assessment for rehabilitation tool. So this is straight from the National Stroke Foundation guidelines and their practice points and demonstrating that. The objective was to try to do a pre-audit to look at our current compliance and if there was any need for a standardised process. And our objective really was to determine the proportion of stroke patients assessed for rehabilitation within the 48 hours as per the National Stroke Foundation clinical guidelines. So we undertook a retrospective clinical audit from September to November in 2018, and we're looking for clear documentation by a member of the interdisciplinary team of the patient's rehabilitation needs. So as I said before, we were looking at patients that were admitted to the acute stroke unit, and we excluded patients that were palliative, who had returned to previous level of function or transferred to another hospital within the 48 hours. So we had 41 cases that were included. So we recorded the date and time of their admission and their date and time of assessment for rehabilitation, as per was documented in the patient's integrated progress notes, and the member of team that completed that assessment was also noted. So as a result, we had 32 patients that were assessed within the 48-hour timeframe, which equates to 78% of patients, and able to show that the average time was 21 hours and 59 minutes. Out of those 41 patients, 0 patients had their that was documented on a standardised form as per the National Stroke Foundation guidelines. So here we have a breakdown of the 41 patients as per the disciplines, and then we also have a day of the week when the patient was admitted and the compliance to the 48-hour rule. So from a conclusion, overall, the assessment was completed in a timely manner. Allied Health were the primary clinicians, and we saw that patients were less likely to be assessed within the 48 hours if admitted on the weekend. And we saw that there was no standardised process for assessment for rehabilitation in place, and there was no standardised communication within team members. So what next? As part of the project, we've created an assessment for a rehabilitation tool, similar to the National Stroke Foundation guidelines, and we're currently implementing that on the ward, and we're going to do a re-audit once it's up and running on the ward to see if that does improve our compliance. This is what the assessment for rehabilitation tool looks like, and it has in the domains and discipline, as well as looking at their current function, whether rehabilitation is indicated at home or an inpatient, and then patient-specific goals and their dates and signed. So it would be more of a standardised process for everyone on the ward, and then also looking at the date of review by the rehabilitation specialist. That there is just an example that we made up of one that was on the ward. Any questions?